Hello, I'm Todd Tracy, the Emergency Preparedness and Operations Coordinator for MIMS. ChemPack is a federal project led by the Centers for Disease Control and Prevention under the Strategic National Stockpile System. The goal of this program is to forward deploy caches of chemical nerve agent organophosphate antidotes across the nation. In Maryland, these caches are distributed across the state and are available for both EMS and hospital use. These caches include medications in both auto-injector form as well as in vials for manual drop and administration. Medications in the caches include atropine, diazepam, and 2-PAM chloride. In Maryland, the ChemPack program is jointly managed by the Maryland Department of Health and the Maryland Institute for Emergency Medical Services Systems. ChemPack caches should be requested in any event that will require a large amount of chemical nerve agent or organophosphate antidote. For example, intentional or unintentional release of a chemical agent might be considered when there are multiple patients presenting with salivation, lacrimation, and other sludge symptoms that we will discuss later on. Each jurisdiction should determine a threshold for requesting ChemPack based on their existing antidote inventory and availability. Most jurisdictions will have limited supplies of antidotes stored locally and should consider making a request early in an incident. ChemPack medications are requested by contacting EMRC Syscom. For EMS use, the incident commander or designee makes the request. Once the request is made, EMRC Syscom will coordinate rapid delivery by air or ground. When making the request, EMRC Syscom will require the following information: an estimated number of patients to determine the amount of medication required, primary and secondary landing zones for medication delivery. When ChemPack medications arrive, they must be received by a Maryland licensed ALS clinician. The ALS clinician will sign for and receive the medication. ChemPack materials will include auto-injectors, vials of medications, syringes and needles, and a small cache of bag valve masks. Just-in-time medication dosing guides, which mirror the information in the Mark 1 duodope protocol, are also included. Now that you know how these life-saving medications are requested and delivered, let's talk about identifying and treating the patients who experienced organophosphate or nerve agent exposures. Organophosphates and nerve agents are a group of highly toxic chemicals that may be released in a weapon of mass destruction event. The organophosphates, or insecticides, may be in granular, liquid, or vapor forms. Nerve agents include tabin or GA, sarin or GB, soman or GD, and V agents such as VX. The G-type nerve agents evaporate quickly or can be dispersed in the air by weapons upon inhalation. The effects of the agent begin in seconds to minutes. The V-type nerve agents are oily and evaporate slowly, and exposure usually occurs from contact rather than inhalation, with effects occurring as soon as 10 minutes or as long as 18 hours after exposure. Early manifestation of signs and symptoms following the vapor exposure of a nerve agent occur in the eyes, nose, and airway. Likewise, the early manifestation of signs and symptoms of thermal exposure occur in the skin and secreting glands tract. The mnemonic P, sludge, MC, and triple Bs can help you recognize the signs and symptoms of exposure to organophosphates or nerve agents. P, pinpoint pupils, S, salivation, L, lacrimation or tearing, U, urination, D, defecation, G, gastrointestinal pain or gas, E, emesis or vomiting, M, muscle twitching, C, convulsions, B, bradycardia, B, bronchospasm, B, bronchorrhea. The Maryland Medical Protocols for EMS contains a treatment protocol for those who have sustained organophosphate or nerve agent exposure. A key thing to remember is that a BLS clinician may administer Mark 1 or duodope auto-injector kits, up to a total of 3 kits, as buddy care to public safety personnel or as directed to do so by an ALS clinician based on signs and symptoms. Midazolam or diazepam should be administered by ALS clinicians only. It is also important to recognize that you have a responsibility as a clinician to not only stop the exposure experienced by the patient, but to prevent further exposure to yourself and others. Early recognition with the use of appropriate personal protective equipment and decontamination are paramount in the successful handling of these incidents. Taking these steps allow you to remain safe, protect your coworkers, and prevent a worsening exposure for your patient. As far as treating these patients goes, in an adult with mild exposure, symptoms include pupil constriction, runny nose, increased salivation, and nausea. Administer 1 dose IM using a duodote or Mark 1 kit, which includes 2 mg of atropine and 600 mg of pralidoxime, also known as 2-PAM chloride. If the adult has a moderate exposure as characterized by pupil constriction, runny nose, shortness of breath, and or vomiting and diarrhea, administer 2 doses IM, one after another, using duodote or Mark 1 kits. Adults with a severe exposure, which is characterized by respiratory distress, respiratory arrest, cyanosis, extreme sludge, seizures and unconsciousness, bronchorrhea, bronchospasm, and or bradycardia, administer 3 doses IM, one after another, using duodote or Mark 1 kits, as well as 1 dose of diazepam, 10 mg IM, or midazolam, 10 mg IM. You can repeat atropine doses every 5 minutes until the secretions begin to dry. Likewise, if the patient's mild or moderate symptoms progress in the face of treatment, you should administer additional duodotes or Mark 1 kits to a total of 3 kits or doses. If the nerve agent exposure involves a pediatric patient with mild exposure symptoms, you should treat the child according to a weight-based dosage schedule using only atropine. If the pediatric patient presents with moderate exposure symptoms, you should treat according to weight-based dosages for atropine and 2-PAM chloride. You can repeat atropine doses every 5 minutes until the secretions begin to dry or a maximum dose of 6 mg IM has been reached. For pediatric patients with severe exposure symptoms such as respiratory distress, respiratory arrest, cyanosis, extreme seizures, unconsciousness, bronchorrhea, bronchospasm, and or bradycardia, you have options. By protocol, there are 2 treatment modalities that are appropriate for pediatric patients with severe nerve agent exposure. Just remember, you can only use one of these 2 modalities for initial dosing. They are 1 duodote or Mark 1 autoinjector, or atropine and 2-PAM chloride supplied in vials. In cases of severe exposure, if no other atropine or 2-PAM chloride sources are available, duodote or Mark 1 kits can be given to any child regardless of age or weight as the initial antidote therapy. To treat a pediatric patient with severe exposure utilizing duodote or Mark 1 autoinjectors, the dosing should be children up to 25 kilograms, 1 duodote or a single Mark 1 kit. Children between 26 and 50 kilograms, 2 duodotes or 2 Mark 1 kits. Children over 50 kilograms, use the adult dosage of 3 doses IM, one after another, using duodote or Mark 1 kits. If the child is seizing, add weight-based midazolam or diazepam to your treatment. Remember that for diazepam, the IV route is preferred, but IM is allowed. The other acceptable treatment plan for a pediatric patient who has suffered severe nerve agent exposure is to administer atropine and 2-PAM chloride from individual vials. This chart shows the dosing schedule for these pediatric patients based on their weight. The initial dose of atropine can be delivered using either an AtroPen or drawn from the multi-dose vials. Now, let's see what you've learned. You have responded on the 4th Due Transport Unit to a mass casualty incident at a local train station. Upon arrival, you are notified by command that a nerve agent attack is suspected. When your ambulance doors open, a firefighter is placed on your unit stretcher by other clinicians. The firefighter is a 31-year-old female who is having obvious respiratory distress, slight cyanosis, profuse tearing, and is drooling. When you assess her pulse, it is 42. Based upon this very rapid assessment and the fact that a nerve agent exposure is suspected, you consider this firefighter to have what degree of an exposure and what treatment would you provide? Based upon the signs and symptoms reported, You would assume this adult patient would have a severe exposure, and your treatment would include 3 IM doses, one after another, of Duodo or Mark 1 kit.